Shak, I would like to show the transesophageal echo live. Can you make the echo big? For a change, this is a large ASD. So, Srija, you can start showing the echo images live.
Around 29 I got. Sorry, 31. Till now, maximum dimension.
How old is the patient?
Patient is an adult.
21 years, 21-year-old.
Is your wire across it, Shiva?
Yeah.
Do you have wire or
Yes, yes, yes.
Okay. No, not sheath across, wire across. But I can take it out. I can make it easier for you.
The retroatic rim is
Okay,
bald.
now there is nothing inside.
just a question? You don't have to obey whatever Zoid says. So, who's doing the POE?
Srija
I am
is
doing
doing. Yeah.
Yeah, don't keep talking then, otherwise Shiva will interrupt
Yeah.
you.
I am just seeing. So this is a 45-degree view, which is showing a deficient retroatic margin, a good posterior margin, and it measures around 24 here. To the bicaval view, 90 degree. Okay.
Show Bina.
It's 25. So the maximum measurement was 31 in the apical 4-chamber view. And other rims look adequate.
Can I just ask, it's Iqbal here, can I just ask a question? Can you just do that measurement again? I was interested to know where you measured to. Is this an offset septum? Because you measured off where I thought you might
Yes. Actually, the yeah, sure.
I want the stick wire again.
So just on that aortic rim that you were measuring. You mean bicaval view or? No, so in the sort of 60-degree view, it was where you measured with the aorta. It was slightly more into the left atrium where I might have measured it.
Yeah.
Good learning for the audience.
Yeah, there is.
There is some malalignment of the septum.
Yeah, there is some amount of atrial septal malalignment.
Short axis. Okay, but go to short axis like 45 or 60 degrees. There you go. That's it. Okay. Now measure.
So this is a short axis view.
Okay, let's measure the defect now.
Cable.
No. Stay in the middle of the cusp.
No. It is not
Stay
there.
in the middle of the non-coronary.
Zahid, the ASD is not there. It is a malaligned. Srija, pull it out.
No.
Yeah.
You see that it's going superiorly.
See the septum. No. You see the septum very clearly. They were right in the middle
around 10 o'clock on the aorta.
Srija, slightly pull out and show that it is going more towards the left atrium.
I've opened a can of worms.
Yeah,
there.
this is.
Sorry about that.
This is this malalignment towards the left atrium. When I pull out, the septum is.
It's the right-left shunting that is pushing the posterior rim towards the LA. That's not malaligned. Dr. Kagi is there. So, what do you think? Is it a malaligned septum?
Teji, hold on. Let's give you a microphone. Teji is an expert on malaligned.
I think that they are correct for the measurement. The septum primarily touching the far back side, left atrial side, and sector septum. Secondum is 10 o'clock for the output.
So what do you think? What happens when the heart squeezes? If you freeze this and then go slowly back and forth, you see a right in the middle of the non-corica. Can you freeze? And now scroll back. There. What is that? That's the aortic. To me, that's the aortic septum.
No, there is no septum.
Go. Keep scroll.
Srija, pull it out and show that it is going leftward.
Yeah, I am showing that. This is the leftward.
See that it's actually going a little leftward. Okay. Okay, keep going inside, Srija.
Yeah, I'm going in.
Keep on going inside. Reform the septum.
What is that?
This is the actual plane. But when you pull it out, it is going leftward.
Yeah.
Come to 90 degree and show. 90 degree. Now you keep rightward rotating.
So, so I'm going to ask the audience, okay, so next question for the audience, hands, is it malaligned or not malaligned? So is it malaligned, hands up? Okay, is it not malaligned?
There is some malalignment.
Okay, we all think it's not malaligned, sorry about that. But Bharat's with you, so...
I have a question to all non-ballooners. How do you sleep at night? Choose your device. I thought you were going to say, how do you sleep at night? You don't balloon. Very happy. Excellent. I didn't get it. Say it again. No, okay. In the country policy. No. So I measure the defect in three views: short axis, bicable, and force chamber. Okay, and I will include the thin, flimsy septum in each side, and then I will take the average diameter. Microphone. In this patient. Use the microphone, Peter. Can't hear. What would you do if you now in Madras have a DOE? So what would you say? So if look, there's one plane, there is of course one plane. Yeah, so I think this is a very difficult case. I don't know whether it is possible to put any device in, but without any balloon testing, I think you just can have trial and error. Peter, your question desired is what size device would you use here, yes? Yes, exactly, without a balloon. Absolutely. So let's give a number. So give me three views we'll measure, and I'll give you the number.
So far I've got 31 and about 23, and then the last one is missing at the moment. This one that we're about
28.
31 in four-chamber view was the biggest.
Yeah, that was the biggest.
And in short axis, if you measure now, please. In atrial diastole, you have to measure in atrial diastole, not systole.
I don't have any ECG connectors. Yeah.
Well, you can tell the
Yeah.
when it gets big. Atrium gets bigger, you know. Okay, that's it. Measure that. Yeah. This is a great case. This is a fantastic, very good thing. Shiva, this is a fantastic case. Thanks for choosing this.
27. 27.
Yeah. Okay. And now, so we have bicable view. Let's measure in bicable view. Bicable, there was virtually nothing there.
Show the superior vena.
Shiva, we're seeing your hands now.
Show
You're not
the.
doing anything naughty with your hands, Siva. We're looking
He's hiding a device.
God knows what it was.
He's hiding a device, yeah. He's decided on a device size.
What is a bicable view?
Yeah,
Bicable
yeah, on a left.
Show the echo. Echo.
What's the
I-
diameter in bicable?
Yeah, I'm exposing the ASD only when I'm leftward rotating now.
Okay.
Yeah, so there's no... That's not bicable reading.
Yeah.
So it's 0 on the bicable.
We can measure it.
We can't see it. How can we measure it?
Whatever she sees, right? So you see IVC, right?
Show the echo.
So we're not going to get the answer so far.
show-
27, 31 are the two sort of dimensions we've got. You want a third one? We can't.
Bicable?
Okay, they can't see on the bike cable. That's the problem.
Did you measure bicable view any?
Yeah.
There was no defect on bicable.
No, Srija, Shaq, on a bicable view, after she
Otherwise,
rotates leftward, there is a.
The bold aorta or not?
It's around 29.
Bold aorta. How much? Carries a higher risk of erosion.
29.
Shrija, what did you say? On the
29.
bicable is a risk
29 is the measurement here.
Right, 29. Hold on. I want to get guys to say just a number. I don't want a question. So give a number with 2 digits.
29.
31 was
31.
Not you, Shiva.
maximum.
I'm trying to get... I give up. I was trying to get Zahid to commit himself. Yeah. 32 or 34, that's 4 digits, but that's fine. Okay, Shiva, go on.
No, it's 31.
Online question.
Online question.
Hold on, Shiva.
So one of the question is by Ong Sabli, and poor LT rim is very risky for LT erosion. Erosion expert is here. So This is the pole aorta.
This is the maximum
And the
dimension, Sriju.
oversize
In which
31.
very
You have
risk
we have
factor
reported
of,
32
erosion.
with a totally bald
And
retroactive
one
margin.
would say the,
I just
how
saw.
to minimize the size of the device.
So, couple of things very important. So when you look at the aortic rim, if aortic rim absent, not that, we must all remember that.
Pole aorta. Multiple views.
In multiple. That's the key. Multiple. If you see aortic rim and you go from 20, 30, 40, 50, 60, 70 degrees, so you're seeing the aorta in all these views. If you see aortic rim in any of these views, then it's not aortic ball aorta. Ball aortic has been in 3 consecutive views. If you go to 30, 40, 50, you have ball aorta,
Heparinized
then
fully?
you have a high risk. So this patient
Full
has
heparin?
Okay. So we'll ask Teji later on for his views, but go on, Jae Young. Any other questions?
Yeah, also we have
Srija, measure now.
in
Yeah,
multiple
it's much larger.
Dr. Rupesh Natarajan. In multiple ASCs,
That's
and
enough, Srija.
experience using
Just
combination
record
of
it and keep it
devices,
frozen.
ASO and Go,
Frozen,
etc.
Srija.
Any comment on how different devices
That 34 when you
interaction
get right?
with each other and
that-
or distal susceptible?
I think we'll come back to that. Let Shiva. Shiva, tell us your number, or well, not the number, but the device you were hiding in your hand.
Yeah, Shaq, the measurements that we made, we had actually made a detailed assessment of this patient in the outpatient clinic with a transesophageal, and the measurement was 32 millimeter. So with an absent retroaortic margin and a relatively smaller posterior as well as inferior margin. The posterior margin was 5 millimeter and the inferior margin was also 5 millimeter. So we have decided that we are going to upsize the hole. We don't use balloon sizing. So for a 32
Don't
mil,
tell me 40.
yeah, I have decided on a 40. This is a cocoon device. It's a nano platinum.
How about the IVC rim?
IVC rim is about 5 millimeter.
5 millimeters. So it also carries high risk of embolization as well as erosion.
Let us,
It's okay. The SVC rim is different. SVC rim is deficient, almost absent. That's bigger concern.
Sure.
If you ask me, this particular patient, everything is good except that superior defect. Superior defect, it means the high risk of the erosion on the roof of the atrium.
May I have a question? The 40 millimeter cocoon, what is the left angle in total?
it is 54 millimeter on the left atrial side and 50 millimeter, 54, and 40 millimeter on the other side.
Okay, so are you going to deploy in the vein or
Yeah.
are you going to deploy in the atrium?
Yeah, I wanted to deploy in the vein, but now it has come. Okay, it's prolapsing now. So I'm going to recapture. I was intending to deploy from the pulmonary vein.
That's appendage. You want to pull back and then rotate clockwise.
It's not appendage. It's not moving.
So can we see on the echo? Just show us on the echo where that is.
Which one?
Suspiciously like
Where is the
appendage.
device?
Okay.
It's in
Get
the-
me again the
Shiva, you may have to pull back to the middle of the spine before you go in the left upper vertebrae.
yeah.
Way back.
I will again get it with the catheter. Sister, get me that.
I think that's really safe. So that's a very safe practice, not to poke around. To just take the time. That's a really good practice, Eva. Well done.
Alright, if this continues to protrude, would you recommend any other technique to use?
We would do it prophylactic.
Prophylactic? What?
We'll not try any other technique.
No. I think he's asking about pulmonary vein deployment.
Which technique would you, if it doesn't continue to
I would
protrude?
do a balloon.
Balloon assisted technique?
I
Who
would do it
described that?
prophylactic.
Who described that? Prophylactic means from the beginning. From the beginning, you put another wire.
So Barrett, where would you put the balloon?
Usually, we would put the balloon in the LSPV and deployment from the right superior pulmonary vein.
Yeah.
The only time when we go towards left superior pulmonary vein, and this we have learned over last 6 to 9 months,
is when there is a malalignment between septum primum and secundum. I don't know why, but somehow we missed the upper rim of the septum primum, and device tends to get embolized. So from that time onwards, all malaligned ASDs we close from left superior pulmonary. We have had 2 embolizations in a period of 1 month. Big ASDs, but with malaligned.
Okay. So, Bharat, quick question. You in your talk you mentioned multiple deficient rims, large ASDs are at risk. Here you look at anterior superior rim is almost absent. Posterior rim also is.
But I think Srinath, the device will hold. Yeah. If there is no significant malalignment, which I'm not able to say with 100% certainty, the device will hold. I think these rims are good enough for the device to hold.
Teji, what size would you have chosen for this defect, and would you use a special technique?
They said 30, or
he's using 40.
Yeah, but the maximum 32, right? So that I don't have that. We don't have that 40, but I said definitely we use for that 38 or something like that.
Okay. And you would use a special technique to do this, or?
If I use the occlusive device, it's simply much more the simple technique for the flexible. It works very well. But otherwise, as we use for the Ampressa Pro, the balloon, I think.
Okay.
Yeah. Is there any recommendation for using softer devices for the deficient retroatic?
I mean, soft is always great, right? I mean, there's no question about it. We can never fight that. But if size, there is a reason Occlutech and Amplaster come in 1 millimeter increment from 4 to 20, and then 2 millimeter from 22 to 38 or 40 millimeters. There is a reason. Amplaster wasn't crazy to make 23 different sizes. The reason is if you have a self-centering device, you should size it. Don't undersize it. Don't oversize it. I've done 2,200 Amplaster cases. I have never had it. So if you look at the incidence, I should have had 6-7 cases of it. So size it, don't oversize it, don't. That's the whole premise.
And the device behaves differently. Softer device and so-called rigid device.
Okay. Yeah, we're about to deploy again.
So you're using left upper for remain technique now, Shiva?
Yep.
Okay.
Show my RA disc, Srija.
Now tell us, go on, Shiva. Tell us what you're doing and what you're thinking.
So now, once again, I'm just confirming that my device has reached the RA.
There you go.
Fluoro, store this.
Yeah. Right. So store that, but talk us through what you did, because your hands were probably doing something different.
Srija, show me good echoes. Echo big. So pull it out to 0 degree. Come out to superior vena cava and go in progressively down.
Yeah.
Now go to 0 degree.
No, the image is not.
Okay. Now pull it out fully. Show me the superior vena cava. Super. Now that's aorta and superior vena cava.
Yeah, it's
slowly
gone
go
in.
in.
Yeah.
The left atrial device has formed well on the superior aspect.
Yes.
Posterior rim is there. Color the posterior margin. Make the colors very small. Zahid, this was the thing that I mentioned. The posterior margin was smaller. Okay, now rightward rotate and get the posterior margin in the center. Perfect. Now keep going inside. Keep going inside progressively. Keep going progressively. Super. Super. Now stay at the same position. Go to 30 degree. So now we are actually going down on the margin, postero-inferior. Keep the color sector very narrow, only to the posterior margin. Very narrow. Very narrow. Narrow. Make the picture larger. Depth. Fine. Super. Slightly push the probe inside.
Shiva, what we need to see here is a mitral valve.
Yeah, we'll show every margin. Now I'm concentrating on the postero-inferior. Now keep going down, 50, 60.
Yeah, I'm going down.
Perfect. Perfect. Okay, now push it inside a little bit. Slightly retroflex. I'm able to see the inferior margin. That's fine. Okay, now come to 90 degree. Show, no, 90. Keep going inside. Now, the depth can be the same. Make the depth larger. Push the probe inside and retroflex the probe. Fine. Now come to the opposite side. Now you go back to 0 degree and concentrate on the
We want the
anterosuperior.
antro, fine.
0 degree again. Yeah. Now concentrate on the anterior end. Nicely pull it out.
Let's see four chamber view, see the mitral valve.
We will do that. We'll do.
So the anterosuperior margin is
slightly
flared.
even come out, Srija. Okay, start coloring from here, only the anterior margin. Now make it narrow. Okay, keep progressively pushing inside. Perfect. Keep on going inside. Still
Yeah, I'm
iota
going
is
in,
there.
I'm going in.
Now we are going to get the mitral valve. Okay. Now leftward rotate and get the mitral valve opened. Go inside further.
You want the mitral margin, no?
Mitral valve itself. Get the mitral valve. Leftward rotate and push it inside.
The image is very bad.
You are getting disappear, right?
Yeah.
Okay. Now switch over to transthoracic. Transthoracic apical view.
Can we stick with the transesophageal, because I think we do need to get this mitral valve sorted
We have to look at the mitral, and you may have to suction this out because there may be too much saline there. That's where image is ugly, so sometimes that helps a lot. But I would look at four chamber view, 0 degree, get rid of the aorta, see the mitral.
Srija, leftward rotate. And
For
push it
some
inside.
reason, the view is not coming.
Okay, well, can I suggest something?
Apical four chamber.
So can you go transgastric?
Can we do a transthoracic?
Transthoracic. Go for
Yeah.
it.
No, would you, before you do transthoracic,
Okay.
do transgastric,
Transgastric.
and focus on the mitral valve in transgastric.
Go further inside, deep inside. Okay, now flex, anti-flex the probe fully. Okay. Now come out on the 0 degree to 90 or something, then you will get the longest. Now keep on coming out. The degrees. You get the LV in the center. Rotate and get the LV in the center.
Maybe you can comment. I got it. Not getting.
You flex the COE probe and then rotate to, it's coming.
This is the mitral valve in short axis. Anterior mitral leaflet and the posterior mitral leaflet. I will now get the focus onto the mitral valve. Now I am going for perpendicular to this. So this is the left ventricle in long axis.
The picture's almost too big for me. Can you make it slightly smaller? I can't see the whereabouts we are. Thanks, Siva.
This is the mitral annulus. And my device is slightly.
That's a very good view, because you do see the reverse of what we would see with the four-chamber view. We got the whole of the disc just above. If you plane it through as you're doing, we'll see how far back it goes. It looks like it's not going to touch.
This is the posterior. This is the posterior mitral leaflet and the anterior mitral leaflet.
Shiva, on the QE, if you just try 150 angle, yeah, and now rotate towards the atrial roof.
Atrial?
Show the left atrial roof. Oh, yeah.
I have to come out. I am in transgastric now.
All right, yeah, okay.
I will get it out. Now I will show you the long axis view. This is now the.
There, nearly.
This is the mitral valve.
That's it. Yeah, but go 150. Pretty close.
I'll freeze it and show you.
Okay. And then rotate. Just follow that device towards the left atrial roof as well, and then back towards the mitral.
Some MR.
Shaq, you are conducting an echocardiogram exam for me.
Yeah. You didn't think I could do this.
Okay. But what I would like to show is that the device is not being touched by the mitral leaflet.
Shiva, can you show us in 4-chamber view or go to 180 now?
Okay.
Ever go to 180 like you reverse? Yeah.
That is the
Reverse, yeah.
this is the mitral valve, LA to LV. The moment I get it in the middle, the picture becomes little suboptimal. You see here now? Okay, I'll make it.
We got to look at this mitral valve very carefully. I'm not happy about it. I'll be honest with you. You can prove it, but I'm not. I think it's a very big device. It works. It works. Hey, Peter, do you have a comment? Microphone.
See that mitral valve?
Yeah.
I think the problem with all these mitral valve things is that the device is always in front of the valve. I think you should have a transthoracic view as well, because then you have the valve in front of the device, and that perhaps might clarify the situation a little bit better.
Whichever it works, we need to look at the mitral valve because it's a pretty large device.
Can you see it, Zahid, now?
6 by 28 by 31. Yeah, I do see it, but remember the excursion of the mitral valve. You know, mitral valve annulus is about 29, 30 in adult, right? So excursion of the mitral valve, that part that sits by the atrial septum, is pretty big. You are looking at one area. You have no idea. That's why people have mitral valve perforation 6 months later, and they show you the echo, and it's not touching it, but it's perforated because you never look at the whole excursion. And one of the ways to do that is when you're at 0 degrees view, when you don't see the aorta, you pull back the transducer of transesophageal echo, and when you pull back, you start seeing the aorta. So you go from the coronary sinus, which is the posterior most structure, to the aortic valve. That's the way you can look at the whole excursion of it, and that's what you want to see here. I don't like this picture.
Okay.
I'm sorry, but it's too big for me.
Yeah.
This is a very big device. So we got to make sure you're just looking at one area. There's a whole 29 millimeter and half of that diameter where the device is sitting. It's very important to look at it.
The left atrium,
Yeah, I mean it's touching it there. So when the patient is awake, his blood pressure will be higher. It will be totally different dynamic.
The angulation is such that it's pointing towards the left atrium quite a bit.
Yeah. But it may not change because the device is so big.
Can I just go back to? Can you just show us the lovely echo picture? And we're a bit nervous, but can you just go back to the fluoro to make sure that the waist was properly formed? Can you give us the fluoro aligned onto the waist? Can you give us that?
Yeah, show an left atrial LAO view. LAO view.
LAO cranial.
Get me some more spirit. Sterlium.
He's dropped the mic. He's so excited. What's in that bottle?
Go more LAO. More LAO. Till the device comes perpendicular.
Keep going.
Further. Further. Further, further. Keep on going further. Come on, listen, Mohammed. Keep on going further. Fully go further. Further. Further.
This is a cocoon.
Go cranial now.
So there'll be a degree of it sort of centering up a bit when you release
Get me
it,
some
unlike the
contrast.
opposite, which remains in a reasonable position. So there will be a bit of pink when this is released. What do we think about the waist of this device? Forget the micro for a second. Hands up says the waist fully formed. Hands up. Waist fully formed. Okay. Waist not fully formed. Okay. So most people are saying the waist not fully formed
Contrast.
yet. Siva.
What do you mean?
If the waist is constrained still, then you may have oversized the device.
The device seems to be touching the mitral valve.
No, forget that. The mitral valve is a separate issue. But even if it wasn't touching the mitral valve,
Go more leftward.
To me, that is the absolute contradiction.
More leftward.
There is no absolute contradiction in ASC closure except it's impinging on the mitral valve. You're really hurting.
I think another concern is that once he releases that, it's going to drop on the left side even further and will definitely be touching the mitral valve.
Go
I
further.
think this is too big a device.
Further cranial.
I completely agree with you. And also when the waist forms, further forms, it's going to dip down.
Go more leftward.
Yeah, I also wonder how they getting better. Yeah, because previously the
Table up.
heart rate was 120 or 1, so they're really worried about that. Something like an arrhythmia or that. But now they're getting better.
In the audience,
Srija, get
show of
continuous
hands
echo.
those who are happy with the device and the mitral valve.
Okay, so a couple of people are happy. Who is not happy?
The whole audience,
Well, I think it's
99%.
because you coaxed them saying they're not happy.
Yes, the concern I still have is the angulation of the device pointing towards the left atrium. It might ping, but it might not, and it's close to the mitral valve.
So, Siva, what are you going to do? You've got a choice, haven't you? You're either going to say, forget you all, let's do what I normally do, which is to release the device, or are you going to say, actually, I might put a smaller device in?
Come to AP view. I normally don't go for these LAO projections and all. Iqbal, I look at it on AP projection, transesophageal echo, and then take a call.
Shiva, on transthoracic, again you put color there, transthoracic close to the left atrial disc, because I saw some rigor close to the left atrial disc on transthoracic.
No, actually there is no flow, Bharat. But do a
flow, the MRI thought, towards the disc,
yeah,
on the LA disc.
You are showing transthoracic, Srija? Okay. I did a wiggle in between.
I think you're right, Siva. It's not going to fall out. That's probably not the concern we have.
Yes,
So magnify that LA and mitral valve only. Actually, let me tell you, Shaq, it looks good to me.
Okay, well, that makes that decision easy then.
In the end, all these cases, Siva, it's your patient, and it's your responsibility, and you should do what you think is right.
Iqbal, now you see, look at the mitral valve. Srija is now magnifying the mitral valve, and you just see the leaflet, and look at the color. Put the color. It all looks nice, Iqbal. There is some tricuspid regurgitation on this side, which probably was there before.
Yeah, I mean, it's a really good case for teaching, okay, and I think we've got a hefty load of discussion in the audience, but in the end, you are the operator and we'll support what you want to do, because we're not in the room with you. So, one more comment.
I think we all would be very happy to see a TE in 1 year. How
Yes.
that looks like.
I didn't follow that. What was that?
We want to follow up Echo in a year's time, Siva.
Oh, sure.
I just have one question. What's the
T again.
choice? What's the reason for choosing a 40mm device and not something smaller?
I mentioned it.
The defect was 29 by 31. So why did you go up to about 40?
See, I mentioned to you earlier, this patient, I myself did an echocardiogram. It was a clear 32mm, and with small posterior margin, small inferior margin, absent retroaortic margin, strongly thought about it. You can now look at one of the picture. It's only the anterior margin where the LA disc and RA disc have separated. All the other places, assume the posterior, postero-inferior, inferior, the device is in contact totally. LA disc and RA disc are in contact. That means that the device is optimally sized. If the patient is having an absent retroaortic margin, it has to flare on the aortic end. So that is the only place where it is flat. If I had oversized this particular device, the posterior margins, the posterior discs would have been separated out. Inferior disc would have been separated out. Now we are having posterior and inferior margins touching each other. So I do agree with many of the experienced operators, but this looks actually good to me. In fact, now on transesophageal, the posterior-inferior margin that Srija is showing now, the two devices are touching each other. The two discs are touching each other. This means that it is not oversized.
There's a question. Shiva, there's a question.
Oh, the question of affirmation,
device were put for a home, but not for a heart.
Very good. Very
Shiva,
philosophic.
can you?
One second. Nick, you have.
Hi, Siva. This is Nick. You're a great teacher, and you give us a great teaching session. Could you teach us this thing with a smaller device? Is that possible?
You want to downsize? How much do you want to downsize?
Shiva.
Look, we have had some various discussions about sizing. The largest diameter we have had was 32 millimeters. I remember.
Yep.
I fully agree that with the small rim upsizing is very helpful.
Get a Cocoon 36.
I do not believe, and that's my humble belief, that the bigger the better. I think a little less would be better in this patient, and I think being a great teacher and with your experience, I think you would have better success with a device, let's say, not 40 but 36, something like this.
I will do that, Nick, now.
You've made him change his mind now. Bharat, what were you going to say?
My only thing was before retrieving the device, if you could have just measured the waist of the device.
Put it back in, Shiva.
Bharat, I was precisely telling the same thing, Bharat. Actually, the device is, the posterior, inferior margins were all touching each other. That means, show that.
I completely agree with that.
Yeah,
My only thing was, with that kind of touching of each other, what was the waist size?
Okay.
It would have been good to have some idea.
Show me that LEVO picture. LEVO picture. LEVO.
Nick, come to the microphone.
Show me the place where the
So now that he's taken it out, you've made him take it out. What size do you suggest he tries?
Well, I mean, we had the 32 millimeters in measurement. We had the very good argument by him that small rims need a little bit more support, etc., etc. We had Saeed's recommendation. I mean, we all know Saeed is Mr. Erosion, that's for sure. And
so don't listen to him.
So, but as he also said, his upsizing is fine, and we see that 40 millimeters is just, in my humble opinion, overdone. So I would go in between these 40 and the 32, which is 36.
Thank you. Thank you
Okay,
very much.
we'll try.
I just want to clarify, whenever you have thin posterior rims, like you were saying, device will always touch there. Whenever you have thin IVC rim, always thin device, the disc will always be closer. That doesn't mean device is not oversized. Oversized depends on when you look on the aorta. When you look on the aorta and the waist is touching, and every time the heart, distally in the aorta expands and you see the device opening up, that's oversized. And that device is clearly oversized.
Zahid.
It should be.
Yeah.
I mean, the discussion.
It's got to touch the aorta somehow, isn't it?
Waist should be touched. The whole idea is the device is going to splay, and we want that on the aorta.
Yes.
We don't want the waist
Zahid.
touching.
He's taken the bloody device out now. So two numbers. What
36 Cocoon.
I'm completely okay with 36 at Nick's.
Okay.
Okay. Show the device. Give the device to me.
So can we get the audience today? 34, hands up.
Show the device.
36, hands up. 38, hands up. Okay, 36.
Oh, there you go. He's showing 36.
Okay. Siva, just make sure you're not listening to us stupid people. Just keep on looking after the patient, okay?
This is very educational, Shiva. Really well done so far.
Kudos to Nick. Nick, you're the man.
So
in support of Bharat's comment,
on my
I think the measurement of waist gives more information.
heparin, it was given about 40 minutes before Bharat.
Do you check ACTs or just keep
we check it if it is more than 1 hour. Within 1 hour, 100 units per kg we give, and that's it.
Okay, so now interestingly, 10 years ago, 100 units per kilogram gave us an ACT of about 300. I don't know whether anyone else experiences, and now 100 units per kilogram with inflation often doesn't give us up above 250, and I have no idea why that is. But it seems to be universal in the UK at least. Maybe Brexit again.
Brexit again.
We're getting the cheap heparin in the UK.
Yeah.
The old one.
So Shiva,
Yeah.
when you do this bit, I was just going to ask you, that's what I was asking before, talk about that pulmonary vein deployment, what hand movements you make to pull, push, what?
Okay, now keep showing 50% my hands also. Fluorostore this.
Okay, so,
but it looks,
what did you do? Pull your left hand or push your right hand?
This here in the previous deployment I pushed my right hand, but in this particular I did not pull anything. But it looks very undersized to me, like it's very unstable looking. This will, if I leave it, it will embolize.
I would take it out already.
No, color it. This sort of undersizing and all are very risky, and these are all recipes for disaster.
Correct. Show Zahid the mitral valve before you ask.
Absolutely. That's an absolute contraindication.
In fact, it's not whole. There is color across all the edges. It is all. It's just simple.
Shiva, give it a time. Give it time. Promise. Then you can do Minnesota wiggle as well.
Show the mitral valve.
It looks okay.
It's same position or slightly worse than the previous one.
Is it definitely across the septum, though? That's the question. I'm not sure it's actually fell in the same beautiful way the other one did.
Srija 0 degree. Srija D 0. Srija just be there.
There you go.
Okay. Get me with back that 40 device.
Shiva.
Yep.
Shiva.
Yeah.
Right. You do what you want to do and don't listen to anything that
No problem. Just give another 2 minutes and I will be getting that 40 inside. I am de-airing the sheath.
That's exactly right, Siva. You've had a great educational session here. You chose a device size that has some issues with it. We've chosen a device size that's fallen out. And so your issues are much more than our issues at the moment.
So when you do the 40 again, do it better than the last time.
Iqbal, I would not, on my routine day, I would have just left that 40. But I wanted to respect all your sentiments.
I really appreciate.
But let me tell you,
in the room.
Directly when you are on the floor, you can take far better decisions. Then, in fact, I also used to take different decisions when I sit as the chairperson. But like directly having seen the outpatient echocardiogram.
And Steve, that's why I said several times, it's your patient, it's your decision, you should do what you want to do, okay? And we really appreciate in the room that you chose to take it out and put a smaller device in, which we all agree, I think, apart from Zahid, that it's too small. Oh, so Zahid said, okay, so hang on. So let's ask the room. So that 36, was it fine? Yes, one says fine. Any other fines apart from these two?
Get me the
Was it too small? Hands up for too small. Hands up for I'm too tired, I don't want to know anymore.
Okay, right. Shiva, don't rush. You take your time.
Yeah, we're going to look at this beautiful result.
Let's not distract him too much now, because it's... Oh, I thought he was delivering the device, still the catheter.
No, I pulled it out to the
So,
inferior.
whilst you're doing that, just out of interest, Bharat, would you, or you said balloon assisted, I was thinking whether you would do a right upper pulmonary vein.
Even this technique is very good what he's doing, and more or less he's doing it predictably. So I think in this case, this is a technique.
Okay.
The problem about left superior pulmonary venous or right superior pulmonary venous technique is it is not so predictable. Sometimes you are too much inside, so there is no disengagement, and sometimes you are too much outside, so there is a premature disengagement.
Get me this one.
Predictable, you may have to use some more modification.
Get me the amplat superstrip.
Well, we're learning a lot because that is he's done it twice.
Get me another 14 French Mullin sheet. Another 14 French Mullin sheet.
In when Shiva put the 36 millimeter device, the device position was okay. I don't think so. That there are
because in the frontal view, it is looks like a little bit horizontal, which means that some limb may be prolapsed. So we
you have to allow the
didn't
catheter to
observe all the rim. So if we do some balancing technique or something more predictable way, and the device position is okay, and then it prolapses with some wiggle or without wiggle, then we can sure that 36 millimeter is too small. But in this case, we don't know.
I still believe that 36 was actually okay device, but that's.
I think that's going to irritate Stephen. So we're not going to ask him that.
We won't suggest, we won't let him hear that, no. But it's a good idea.
Yes, I think we all agree that 40 is oversized. We all agree that 36 undersized. So a few millimeter less with 38, it may work.
Yeah. Jay Young, any questions from the online?
The multiple device system should be addressed later, after lecture on that topic.
But no other questions?
We have Mario there. Mario, what would you think 36 was too small? Or 40 too big? Or
Mario, sit down while coming to you.
Well, based upon the immediate results, obviously that 40 was too big and the 36 was too small.
38?
So what?
I mean, I think that modification of the implantation can make a difference. That's the issue.
So what would you do now, Mario, in terms of...
Well, there are also, you all know the other modification of the implantation. Right upper pulmonary vein deployment, balloon assistant deployment, all that stuff. I mean, they can make a difference. But certainly I will try for the third time a 36 instead of 40.
Okay, thank you.
Retry a 36?
Yes, that's what Mario recommends.
Yeah, Siva, do what you need to do, Siva.
But with a different technique. But it must be pretty late over there, so Shiva, I don't want you to get so exhausted you can't make a decision. So you do what you're comfortable with. And you're hungry as well, yeah.
No, that was the other patient. The other patient is now fed. They're having dinner. That was the local anesthetic patient.
Howdy? What was the question?
There wasn't a question. We're just asking, are you in the same pulmonary vein as you were before?
No, it is in the lower pulmonary vein. I have gone into the lower. Actually, there was because of my repeated sheath manipulations, the Cook-Mullin sheath got little bit kinked. So I had to change the sheath to another 14 French sheath.
Let me just say you're doing a fantastic job there. We're learning lots.
With
Every 2 minutes you...
Oh, Mario, hold on. Mario's want to comment.
An additional possibility that we did not mention is to use the double curve sheet, like the Hauser's lock sheet. That's another additional attempt that could be made.
Absolutely, yeah. Hopefully he doesn't have that.
Another suggestion is, in this image now, the anterior inferior ring is not so big at all. Perhaps trying to test it with the balloon side, how the behavior of the anterior inferior ring.
I will recapture this one.
He's deploying. So let's have a quick look what's happening. Yeah. So that's what you were saying, Barrett. It was a bit too deep. It wasn't releasing.
But he's in the lower segment of the left, not Cobra.
Yeah. It's a Cobra. I will set it right and then. Actually, I should have chosen a left upper, but the left, it was entering the left lower and just I accepted it. Sister, I want a RCA catheter.
So you might have a 38 device available.
No, no, but I feel the 40 is correct, Shak. You see that the Cobra is there.
The Cobra.
Yeah, I will.
So for those who've never seen the Cobra, there it is, a very good example of a Cobra.
Just ask them to show that last image and show it again whilst you're getting rid of the Cobra.
Is it possible that another make of a device with the same size will perform differently, like an amplifier or Bluetooth?
Difficult to answer that, isn't it? Really,
No, but what was the problem of the make of the device here?
I think I can try to answer the question. Yes, it can. Because remember, you have a device size from 4 through 40, for example, and device thickness of the wire has to change. Otherwise, a 40 device made by the same size wire as 4 is made will be like like spaghetti, right? So device size, for example, like amplifier, thickness increases at 11, 18, 30, 26, and 32. So at that time, so it can make a difference because other devices, the wire thickness changes at different diameters. So yes, it can it make a difference? Yes, theoretically, yeah, you could be right.
Show the device.
So we're not going to disturb you, Siva. You crack on, okay? And let's see what we get.
Is the same 40 sister? Sure, no? Not the 36 again. Okay.
Just a quick question to the audience, especially to the US group. Apart from Zaid, are there anybody who are using large amplifier devices for this ASD?
Is there too many Americans?
Is that Srinath?
I don't think so.
Yeah, it is.
Yes.
Any Americans in the audience?
See that? Oh.
Who let you in? Where are they? Okay, we can't answer that one then, Srinath. I can't see anybody. They're not volunteering. Hands up those who are American. This is going to sound really terrible, isn't it? Yeah. So Srinath's question about
Fluorostore this. Fluorostore and show it.
No. Okay.
Shrija, again recheck the positions.
I missed the deployment in there.
I'm showing you, Iqbal, I'm showing you now.
Wonderful. I'm sure it looks beautiful. Let's have a look.
Shrija, you just each and every margin slowly assess.
So this currently looks a better position, Shiva.
I think the effect is bigger now.
I'm trying to be optimistic.
Yeah, looking good.
Reproducibility of the left upper pulmonary vein deployment. You've done exactly the same thing twice with the same device.
Not twice, several.
4 times.
Echo big. Just show the echo big. Okay.
Right.
So this is now the superior vena cava, aorta, superior margin is okay, posterior superior margin is okay, mitral margin is okay, retroaortic is okay. Now I am going. I'm retroflexing the probe. That is the inferior margin. Make it larger, Srija.
The waist is close to the aorta, which is fine.
Yeah. Yeah, position is fine. Color out and show the margin now between the two.
To me, it looks better.
The device got shrunk because it was lying in water for some time.
All right, okay. Dietmar.
Hi, Shiva.
Hi.
Fan from Germany.
Hi, Dietmar. How are you?
Yeah, exactly. I have to visit you in Chennai. So my comment is that it looks very nice, and I guess that the left atrium volume will increase over time, and then the left disc will be better placed in addition to the septum as well as to the mitral valve. So my option was 38, but I would use 40 instead 30 because embolization is a bad thing. But I think it will increase over time the left
Thoracic echo?
volume in any case.
Yeah. Dietmar, it was a pleasure to hear you.
What?
It was a pleasure to hear you.
Me too. We are thinking pathophysiologically. Here's some in the panel. I don't know exactly. Okay.
Shiva.
Yeah.
Shiva, this is very unusual because Dietmar sounds optimistic, which is very unusual.
No, Dietmar is a very, very dear friend for me, and
yeah, I know. Okay.
it looks
So
good, Shaq. Nothing.
Thoracic.
See, this is the.
Shiva, you decide what you think is right here. I mean, as Iqbal was saying, to me, it's the mitral valve leaflet and anterior mitral valve leaflet. That's the edge of the disc.
I think it's do you have any experience of the touching device on my anterior mitral leaflet caused mitral valve erosion? Not encroach.
We have not heard and we have not had such an experience.
Reported, but in the case series, they reported that mitral leaflet, mitral valve the erosion, but they didn't describe in detail. Touching or encroaching, you don't know.
It has been described with a cribriform device in India once. Because cribriform device, the edges are a little sharper. However, it has not been shown with regular device. We have not seen. I have not seen so far in mitral valve. Let me also tell you, I have not seen any erosion so far.
So, I experienced a case in which during my initial experience, that mitral valve encroachment was observed, but we finished the procedure and the patient developed the mitral valve erosion, but she didn't want surgery. So as time goes by, the mitral regurgitation disappeared.
Fibrosed up. So how did that happen? Did it heal itself?
I don't know. So I will show you the
device
next time.
Device
Leave it release it. That's fine. You want to release it? We're going to release it.
Srija, now show ya.
Really move.
Show ya. The transistor phase.
So
T.
Shiva, final very quick echo pictures so that we can.
Yeah.
You must
Echo,
be hungry, exhausted, and your team as well.
No, not hungry, Shaq. I can. Okay, echo big.
Yeah, but your team must be hungry.
But it's a pleasure to be amidst all of you, and everyone actually enjoys.
Yeah,
the whole team.
We did as well.
And color.
And color. It'll be good, don't worry. It'll be okay. I'm trying to be like Dietmar now. The color machine is rubbish.
Yeah, correct. Actually, there is some electrical artifact. Doppler, Srija, Doppler. Pulse wave Doppler. Make it brighter.
Last transthoracic, and then we'll jump.
Brighter.
Yeah, you've done very well.
No, brighter, so that they see the E and A waves.
Yeah, we see that. Yeah, very nicely. So Shrija, she must be tired. Show us the transthoracic picture, and then we'll
leave you alone.
Goodbye to you.
So at the end of this presentation, me and Srija will get a European Society certification in echocardiography.
Yeah,
I hope.
and I'll sign it. I will sign it. But looking at the rest of your team, they look
echo big.
absolutely exhausted.
Echo big. No, yeah, actually, I don't think. They're all cheerful. What is echo?
Color it. Can you color that mitral valve?
Doppler it also.
That looks very good. Whiff.
Siva, you've done very well.
Brilliant.
We're going to leave it there with you, and thank you very much for a really educational case. Well done.
Thank you.
Hope to see you soon, Siva. Bye now.
Siva, you take care, and congratulations to the whole team. I think they deserve that as well as. So we'll one more big hand for the whole.
I thank all the colleagues of mine who have been supporting this transmission. I also thank Shaq, host, and Mario, the chairman of the CSI, for giving us this opportunity. And I'll be there amongst you in another 24 hours. Day after tomorrow, I'll come there.
Okay.
Take care, Shiva.
All right.
Bye-bye.
Yeah. Bye-bye.
Okay, Peter, it's on.